And my name is Nicole Reynoso, and I am an assistant professor at Rutgers, New Jersey Medical School. I work in the Department of Medicine section of Internal Medicine and Pediatrics. So today I'd like to present to you all Bridging the Gap, Improving Health Outcomes for Adults with Intellectual and Developmental Disabilities. So I actually recently changed the title because I thought it'd be more fitting for the presentation and the information that I'm putting forth. So that's why it might look a little bit different. I usually present this with my colleague, Dr. Davis, but she's actually studying for her MedPeds boards. So unfortunately, she can't join today. So my objectives for today are to differentiate between developmental delay, intellectual disability, and developmental disability. Describe the factors that contribute to medical complexity, outline a comprehensive primary care assessment for adults with IDD, and examine the health disparities faced by patients with IDD, and IDD is short for intellectual and developmental disabilities. So just a little bit about why I chose this topic and why I thought this was important information to share. So I think many of us in healthcare can agree that the care for patients with medical complexity, intellectual and developmental disabilities can be very rewarding, but I think we can also agree that it can be challenging and intimidating at times. And I think a lot of this has to do with the fact that many of us just feel uncomfortable because either we haven't received enough training or exposure to this patient population. And then when we do, a lot of times we're seeing these patients, say, in residency for the first time, whether that's in the inpatient or the outpatient setting. So it is expected that healthcare utilization will continue to rise as individuals with IDD live longer, and therefore this increases the risk of multi-morbidity in this patient population. I think my idea is, to give this presentation as early as possible to medical students, and then either M1 through M3s and even M4s, and then in residency as well, with the idea that the more we see this, the more familiar we become, and therefore the more comfortable. And I think this is important for everyone, regardless of specialty, because again, these are patients that many of us see, whether that's in primary care, the emergency department, orthopedics, et cetera. They often require a multidisciplinary approach and see multiple specialty cares. Again, it is important because these patients have higher risk of fragmented care, sentinel events, and poor access. And then these barriers to healthcare lead to missed opportunities for prevention. So this is just some data from the CDC. So more than 1 in 4 adults in the United States have some type of disability. More specifically, 13.9% of US adults have either a cognition disability with serious difficulties concentrating or remembering or making decisions. 12.2% of US adults have issues with mobility, 7.7% with independent living, so running errands, doing their activities of daily living, hearing, vision impairment, and then self-care as well. Specifically in speaking about health and disability, adults with disability are more likely to have obesity, smoke, have heart disease, and have diabetes as well. So in this chart, the CDC compares these chronic diseases in patients with disability versus those without. And we can see that for obesity, patients with disability have a 40.5% of adults have it compared to 30.3% than those without. Smoking, same thing, double. Heart disease, 10.4 compared to 3.7, and then diabetes, same thing, double the amount of those as those without. In terms of accessing care, 1 in 4 adults with disabilities, and this is from the ages of 18 to 44, do not have a healthcare provider. 1 in 4 in this same age range have unmet healthcare needs because of the cost in this past year. So again, highlighting not just the disability can be a barrier, for example, but then other things that come into play when it comes to access to care. And then 1 in 6 adults with disabilities, and this one was from the ages 45 to 64, did not have a routine checkup in the past year. So this data highlights that diverse needs, some challenges and barriers that are faced by individuals with IDD, or actually I'm misspeaking, just disability in general, not just specifically IDD. But these issues may stem from the nature maybe of their disability and some of the difficulties that they have accessing care, but then can be exacerbated by outside factors. So, in my opinion, or this raises a question for me, why is it that these disparities exist, and what can we do to minimize them? So I think in order to address this, I'll go through some definitions. I think these are terms that a lot of us use in healthcare, but do we really know what they mean? So I just want to lay a foundation so that we all have the same definition. So the term disability actually includes a diverse group of people with a wide range of needs. According to the World Health Organization, disability has 3 dimensions. So it includes impairment, activity limitation, and participation restrictions. It is an umbrella term that is used to describe any condition of the body or mind that makes it difficult for the patient with the condition to do certain activities, and as a result, therefore, interact with the world around them. Disability can be related to conditions that are present at birth and may affect functions later in life, including things like cognition, like we saw before from the CDC data, mobility, vision, hearing, among other areas. And it can be associated with developmental conditions that become apparent during childhood. Disability can be acquired or related to injuries such as traumatic brain injury or spinal cord injury, and can be associated with long-term conditions such as complications that we see in patients with diabetes, for example. It can be progressive, static, or intermittent. So think of a patient with multiple sclerosis, for example. To further describe disability, the World Health Organization. Sorry, does anyone have a question? Okay. I'll continue. So the World Health Organization went on to further describe disability by creating the International Classification of Function, Disability, and Health, or the ICF model, which was approved for use by the WHO back in 2001, and then was further classified and published for children and young adults in 2007. So this is the framework that's used for describing and organizing information on functioning and disability. And the aims of the ICF really are to establish a common language for describing health and disability as well, and health-related states to improve communication, not just between different healthcare workers, but researchers, policymakers, and just the public in general. So the ICF actually integrates the major models of disability and recognizes the role of environmental factors in the creation of disability, as well as the relevance of associated health conditions and effects. Some of the underlying principles of the ICF include what they call universality, parity, neutrality, and environmental influence. By universality, they mean that this classification really can be applicable to all people, regardless of their physical or condition or cultural context. In terms of parity, I think one important thing that they emphasize is that there's really no distinction between different health conditions, whether mental or physical, and we're not really focusing on the etiology, but rather the disability itself, with the idea that, say, a patient with cerebral palsy, for example, no 2 patients will present the same, and they can have different presentations, disability, and severity of disabilities, even if they are the same. In terms of neutrality, this is just the language that we use when speaking about disabilities. And then environmental factors, again, what things in our everyday lives become barriers versus facilitators for the life of these individuals. Okay. All right. So these are the components of the ICF model, which contain a lot of the same concepts that were part of the original umbrella term or definition by the WHO. Overall, in the ICF model, functioning and disability are multidimensional concepts relating to body functions and structures. There's also activity limitations, which we saw before, and participation, with here the extra focus being environmental factors and personal factors. So that might have been a lot of information already, but does anyone have a question or any questions so far? Okay, so I will move on. And sorry, my computer is lagging a little bit. I'm not sure why. So this is the model itself. And this graphic was released by the CDC and the WHO. And this is how can we can apply the model essentially. So if you actually go onto the CDC website, they actually explain how to use this model and go through each section on how, what counts for what, how you can use it for your patient if you're not really sure how to apply it for them. They also have a qualifier scale that you can use from 0 to 4, being 0, no problem at all, to 4 being a complete problem. And it can also be either not applicable or unspecified. So starting from the top and looking at the health condition helps better understand the context of the disability that we're seeing. And then moving down, we look at the interplay of body functions and structures, how this can limit activities, and then how we can limit participation. And then from the top up, we see environmental factors, again, how they can either facilitate the everyday life of the individual or become barriers, and then any personal factors, whether that's, motivation, the patient's age, and how that affects how they view themselves and their, disability. So this is an example on how to apply this model. So if you think of a patient with cerebral palsy, so that's the health condition right there. Keeping in mind what we said before, that no two patients, will present exactly the same way. So we're looking specifically at body functions and structure. So say we focus on joint function and then the impairment here being contractures. So with, the activity limitation would be here, difficulty walking, for example. And, this can lead to participation limitations, say restricted education, community life, say if they want to get involved in sports, then that could be a little bit different. I think the nice thing about the ICF model too, when we use it in the clinical setting, it can help us think about how we as providers can help patients and what resources we can get for them. So say someone with contractures, right? Do they need physical therapy? Do they need occupational therapy? What other specialists do I need to involve in our care? So I think this is a perfect model to keep in mind when we are seeing these patients. And again, looking at environmental factors, education and support system, right? So if this is someone that is wheelchair dependent, do we have ramps in the school? How can we make education more accessible to them? And then here, this chart is straight from the CDC. They put that this is a 15-year-old male. So how does a patient perceive themselves? What kind of motivation do they have? And what other factors can affect their everyday experience? So moving on a little bit to some more definition, thinking of developmental delay, global developmental delay, intellectual disability, and developmental disability. As a pediatrician, I think these are terms, and even in adult medicine, that we see a lot in the chart. And I feel like sometimes it can be used inappropriately. So I just want to go through some definitions so that we know what each means. And I think a lot of the confusion can come from the fact that they all sound very similar, but they're all actually different things. When thinking of a developmental delay, it means that a child is not meeting expected milestones and is continually behind in gaining skills expected by a certain age. So a developmental delay can actually be isolated and affects just one area of development. So say like a motor delay, or it can affect several different domains, such as speech, fine motor, etc. once more than one domain is involved, this is what we call global developmental delay. And developmental delays can be outgrown, especially if addressed with interventions like therapy, and they can be either short-term or long-term problems. It is important to identify these delays because they can be part of a larger problem that might be going on, part of a bigger system, or disability, or other, can be associated with other disabilities in the future. So especially in the developmental period, this is something that you want to catch early. So in pediatrics, the way we do this is we actually have a lot of in adults, we have annual exams, but in peds, we have our well child checks, and we do developmental surveillance or milestone surveillance. And then at very specific visits, we do more detailed tests of development with very specific tools. At any point, if there's any concerns, then we, go ahead and apply those tools as well. So in speaking of intellectual disability, then this actually can be diagnosed when or tested for when children are 5 years or older. So again, at this point, cognition can be measured. And once you have a delay in cognition and adaptive behavior, then this becomes labeled or diagnosed as an intellectual disability. So, and again, this is when a child is significantly below age expectations for both cognition and adaptive development. So we can diagnose someone with intellectual disability, like I said, at 5, but again, when we can test for cognition and adaptive behavior. But what exactly does this mean? So an intellectual disability is a lifelong condition that can manifest in the developmental years and is characterized by significant limitations in both intellectual function and adaptive behaviors. And it can affect social and everyday skills. This is something that actually gets tested for and diagnosed extensively by either a developmental specialist, a neurologist, or even psychiatry can do this as well. And they have very specific tools that they use to diagnose this. A lot of times children can go undiagnosed even through their elementary school period or school age period, because a lot of them can get by earlier on. But then it's as they get older that we start noticing, that they might be falling behind in certain subjects. And then this is what triggers either the teachers or the parents to go ahead and get testing. And for the testing tools that we use, this is where we use the IQ score, which many of us are familiar with. And there can be varying levels of intellectual disability, from mild to profound intellectual disabilities. Speaking of developmental disability, then this can actually include intellectual disability. And this typically we diagnosed in young adults or children by the age of 22. And again, this is a lifelong condition that affects the person's activities of daily living, such as an ability to interact with the world around them, things like moving, learning, and communicating with others. So here I have a Slido, and hopefully it loads. But what are some common causes of intellectual and developmental disabilities that you guys might be familiar with? You can scan the QR code, or you can just tell me. And I think there's many that many of us might be familiar with. I really hope this works, but if it doesn't, we can just talk about it here. Okay, good. So fetal alcohol syndrome I'm seeing on the screen. And while we put in some answers, I'll say that intellectual and developmental disabilities can have a variety of causes, including genetics causes, chromosomal abnormalities, exposures in the prenatal period, say in someone like fetal alcohol syndrome, if mom becomes exposed to alcohol use during pregnancy. Certain infections like CMV, for example, can lead to hearing and vision impairments. I see trauma, again, for example, in the perinatal period. Down syndrome is a very good one. That and common one that we see a lot, chromosomal abnormalities. Very good. And I will say that there's also different risk factors that can increase the possibility of some of these. So including like maternal age, for example, socioeconomic factors, etc. Shaken baby syndrome, that's right. So again, another trauma-led exposure is another one that we see in the developmental period, and we actually screen for in pediatrics. So here, again, as some of you listed, some of the common causes that I have here, and these are not listed in any particular order of prevalence, but for example, Down syndrome, Fragile X syndrome, fetal alcohol syndrome disorder, cerebral palsy, and autism spectrum disorders are very common ones that we see in the clinical setting. So this is just a group activity that I wanted us to work together through. So now that we have some definitions and some examples of intellectual and developmental disabilities, can you think of a common health condition or cause like the ones we mentioned earlier and apply the ICF model to describe this patient's functioning and disability? You guys can take 3 minutes or so to come up with an example, and it would be great if someone could participate. If not, I'll pick someone. You can take a few minutes. And when you guys are ready, you can just go ahead and tell me. Oh, I can't hear you, Dr. Sanchez.
You can have I don't know, this is the example I was thinking of during delivery, a brachial plexus injury. And that would lead to motor dysfunction in the affective side, the arm. So it would be in terms of body structure, arm with motor dysfunction, and that would impair the child's ability potentially to grip or to raise the arm or to have certain range, which might limit their participation in certain sports, or if that's their dominant hand with writing. And then and personal factors, I guess, if there was maternal diabetes or there was gestational, I guess one and the same, but that made it difficult for the child to pass through the birth canal. And then environmental factors, I'm not sure, but that would be my case.
Good. Thank you so much for that. So good. That's a perfect example of a trauma-related disability. I think environmental factors could be in the future, again, like say in school, what accommodations, say if the child needed any, if for some reason this went on and they didn't get therapy early on, what accommodations you could have in school, let's say. But perfect. And again, I think this reflects how we can use this model to think of interventions that we can do, right? So with this child, you would want to do physical therapy, occupational therapy sooner rather than later, and probably get your neurology colleagues involved as soon as possible. Anyone? Thank you, Dr. Sanchez. Any other examples that you guys might have thought of and would like to share? Okay, so I have one last example, and this one is also from the CDC, and I just wanted to share it because it shows how we can apply this to issues of the mind as well, not just physical disability, but say someone with panic disorder. So then, it becomes a problem of emotional function, let's say a problem of the mind that can lead to difficulty handling stress, for example, and other psychological demands. This can impact their social relationships, personal relationships, and environmental factors could be, say in the workplace, negative attitudes, lack of support system. These would be barriers for this individual. And in personal factors, they listed, like a female who's 27 years old, but, you can think of other things too that could affect this individual. Okay. So, in thinking of medical complexity, so not all patients with disabilities are medically complex, and the opposite is true. But a lot of times, our patients with developmental disabilities can have multiple comorbidities that makes their care complex and requires, multiple a multi-system approach or multidisciplinary approach. So there are many definitions for this term, complex medical needs, none of which are really standard. In looking at various articles and journals, they have different ways of defining this. For example, in one article for patients in the pediatric age, in pediatrics, they say that someone would be medically complex if they had like 3 systems involved with 3 specialty cares. I think overall, some of the things that these definitions have in common is that these patients tend to be affected by multi-system diseases and often require specialty care. They also have recurring presentations to care and frequently rely on medical technology. They require care coordination with needs that may change over time depending on their condition. And because of their comorbidities and sometimes the severity of those comorbidities, they are at increased risk of fragmented care, sentinel events, and difficulties accessing appropriate healthcare resources. And again, this can be due to the multiple specialists that are involved in their care, and then possible difficulties accessing that care. Unfortunately, these patients experience considerate health disparities because of this throughout their lifetime, and these can include limited life expectancy and then greater risk of comorbidities. In this article, Health Disparities of Adults with Intellectual Disabilities, What Do We Know? What Do We Do? It was actually published back in 2015, and they focused on the health outcomes in patients with intellectual disabilities and the determinants of those outcomes. So they actually reviewed multiple publications back in the early 2000s throughout different countries, not just the United States, and they focused on the health of people with intellectual disabilities specifically. So though the articles that they looked at had different approaches and frameworks, they came up or emphasized the importance of 4 common things in minimizing health disparities in adults and promoting health. So one of those being, promoting early identification, inclusion, and self-determination of individuals with intellectual disability. So what this means is just one, identifying these individuals, right? So what are their needs, and what is the diagnosis, for example, in order to get the care that they need and prevent progression if possible, and address any issues in the present time. Number 2, preventing and managing the occurrence and impact of health conditions. So again, even beyond those that might be associated with their condition, preventing other common health conditions, whether that's diabetes, obesity, things that we see in everyone that affect everyone essentially. Number 3, they emphasize the importance of empowering caregivers and family members to meet the needs of the persons that they're caring for, and for promoting health behaviors in people with intellectual disabilities. So how can we do these 4 things in our practice? To understand our patients' needs, we must have a comprehensive approach, I think, with a baseline assessment of the functioning and etiology of patients with IDD. I think there's a lot of work that goes on in pediatrics early on in diagnosing, and by the time that we get these adult patients, a lot of times these patients already have, many things that they've been through, many specialties that are involved in their care. However, that transition from the pediatric to the adult period sometimes can be a challenging one, and many patients can get lost to care in that transition. So one of the things that the AAP is actually doing is that they're really focusing on having a seamless transition between pediatrics to the adult period, really emphasizing that it is important to start this transition at 12 years of age. And ideally, in the adult setting, these patients would come come in with a nice summary of the care that they've gotten throughout, but that is not always the case. I think when you're meeting these patients for the first time, it's important to try to sort all of those things out. And if you don't have a diagnosis for, their reasoning for IDD, try to establish one, getting teams like neurology, psychiatry involved to get a diagnosis and see how to move forward. Even a baseline assessment too, of the patient's cognitive abilities. And I mean that to see how much they can partake in their care, because then guardianship at the age of 18 becomes important as well. Let's see. The other thing too that I think is important is that the care of patients with disabilities is no different than that of the regular population. I think something I see in practice is that a lot of times these patients come in with very specific needs, and a lot of times that's what we focus on, but we don't really dedicate time to preventative care. So again, remembering to screen, and I'll talk a little bit more about this, with keeping very specific things in mind that might apply to the patients. Okay, so in the next couple of slides, I actually want to use a case study to kind of go through the case of a patient that would be considered medically complex. And, I would like to see your thoughts and questions if we can all work together through the case. So in this case study, we have Kira, who is a 21-year-old young woman with a history of trisomy 21. She has mild intellectual disability, history of global developmental delay. She also has hyperthyroidism, asthma, and atrioventricular septal defect with surgical repair, who presents to the clinic for a routine annual exam with her mother. And they actually just moved from North Carolina to New Jersey. Her mother states that unfortunately she had lost her insurance, and so she hadn't been to the doctor for a few years. Her mother is very concerned about her health, and she just wants to make sure that she's getting reestablished to the healthcare system. When you speak to Kira, she says that she feels well, and her only complaint is that when she goes to her photography class, she often has a hard time seeing what the teacher is writing on the board. So just a little bit more about her past medical history again. So she's 21 years old. She has Down syndrome and mild intellectual disability. This is just in terms of past medical, kind of what we said. Her GYN health, she has no issues there. She only had the surgical repair for her heart condition. She does take levothyroxine 75 mics daily, but she hasn't had any recent blood tests, hasn't seen an endocrinologist in many years. So she just has been taking this dose over the past year. In terms of her social history, she lives with her mother, who she relies on for assistance with her medical care and daily needs. She also lives with her older sister, doesn't smoke, doesn't drink, has never had a girlfriend or boyfriend. She does have blurry vision on review of systems and dry skin, and she snores at night, according to her mom. And just briefly looking at her vitals, her blood pressure is a little bit elevated, and her BMI is 30, and she has a murmur, but her exam was otherwise normal. So knowing her case that she recently moved, has been lost to care, hasn't seen multiple specialists, what are some considerations that you would have for the care of Kira? And again, no real right or wrong answers. It would be great if you guys could participate. What do you guys think? So it's this someone that you think qualifies as having complex medical needs, and why is that the case?
Well, I guess when you mention, I guess the ICF model can be applied for any patient with, I think in this particular case, she has atrioventricular septal defect, trisomy, and asthma, so multiple conditions that have chronicity. But her new complaint is vision change, dry skin, and it seems like snoring. So but to be honest, I'm not sure which condition is contributing to the blurry vision, or if it's just that was, there's a change, there's an optic condition that's separate and standalone, or if
Mhm.
it's tied to one of the chronic. So, but just with the vision change, that dysfunction would require, optometrist or an ophthalmologist, depending on the etiology, certain coordination with her school so that she can, or her work environment, so that she can succeed in learning her materials and excelling. Yeah, so I'm not sure of the differential, but it would require, consult and team management.
Yeah, thank you for sharing your answer. Yeah, I think that's kind of, what I want to highlight here too, right? So a lot of times these patients coming to the adult world with many things going on, and I think primary care is very limited in the fact that we don't have a lot of time within one session to address a lot of these needs. So many times our patients with developmental disabilities have many things going on that you just have to take care in separate visits, right? So she's definitely medically complex. I think, one of the things that take priorities in her care is she's been lost to care, hasn't seen an endocrinologist, has been taking levothyroxine kind of blindly, right? So getting routine labs for her would be important. Setting her up with a cardiologist, right? Because she's had this heart surgery and not really following up with anyone. And then in terms of her chief complaints for the visit, right? The blurry vision, understanding that in patients with Down syndrome, for example, they do have risk of cataracts and strabismus, glaucoma. So understanding your patient population. So this isn't easy. And I think that's why this talk is important, because primary care in general is challenging, specifically for this patient population even more. So definitely setting her up with an ophthalmologist. And like you mentioned, Dr. Sanchez, yeah, so this would be a great opportunity also to apply the ICF model in thinking of her blurry vision, right? So what limitations could this have for her? She is engaged in, in this photography class. So how can we help her? What resources can we get for her? Um,
There's a
Good.
couple of comments in the chat. Do you want me to read
Oh,
them out?
yes, please. Thank you.
One said we would want to consider whether she has access to all the necessary specialists she needs right now, which is what you touched upon. And Akimi said, I think the concept of services cliff or transition cliff also applies well here, given that she's 21 years old.
Yes, thank you. Exactly. And it would have been nice, again, having a nice summary, right, of everything that she's had, the specialists that were involved, who she continues to see. She's at a very transitional age at this point. So that transition can be challenging. So again, as I said, ordering an echo, referring her to cardiologists and to specialists, like someone in the comments said, routine labs, maybe a sleep study, endocrinology. And so you did all of those things, and you scheduled to follow her up in 3 months. Okay, just moving on. So she returns to the clinic with her 25-year-old sister, and you review her labs and imaging studies, which are largely within normal limits. You decide not to make any changes to her levothyroxine. She's using CPAP at night, and she established care with cardiology and an endocrinologist. Upon further questioning, it is revealed that Kira's mom has actually been hospitalized for the second time this month, and she's currently admitted in the hospital. So how do you think this affects Kira's care, and what resources do we want to make available for her and her sister? And so what do you guys think? And I can't see the comments. Let me
Can
see.
you hear me?
Yes.
Yeah, so you mentioned that she relies on her mom for a lot of her medical care, so we don't really know how up to speed her sister is, so we'd want to get that information.
Perfect. Yeah, that's exactly right. And I think, this is one of the things that we're noticing, right? As The pediatric population continues to age, right? Our patients with IDD and other just chronic conditions, right? Congenital heart disease, for example, which Kira has, as these patients continue to reach adulthood. We also have to think about the parents, right? I think it would be good to know how much Kira's sister knows about her care in the event that for any reason her mom wasn't able to come to these appointments or be there for her. So again, and another thing to consider here is the legal aspect of all of this, right? In the pediatric period, this is not something that we have to think about because parents come with their kids to appointments and they make medical decisions. But once you're 18 years old, then guardianship comes into play. And if Kira's mom is the only guardian available, in the event that she were no longer here, then who would have, guardianship over her and who would help her with medical decisions? Any other thoughts? Okay. So I'll touch briefly on guardianship before moving on to the rest of the case. So by definition, a guardianship or a guardian is a person or an agency that is appointed by the court to act on behalf of an individual. So this is important to determine in the outpatient setting, especially again around the transition and period into adulthood. We actually recommend that this is done by 18 years old or starting at 17, so that when that transition happens, all of those things are taken care of, especially in times of emergency. So guardianship can be general or limited. So it could be limited to things like education, finances, or medical, or it can be just over the person as a whole. So this is something that you want to consider, kind of as a last resort, because you're really taking the patient's autonomy. There are patients that need that, of course, but this is something that's a legal process and that becomes determined by the court, and only they can change it and modify it. A lot of times, patients like to have lawyers involved. This is not something that's necessary, but to keep in mind that if you have a patient in that transitioning period or an adult patient that comes to you, say 21 years old, this is definitely something that you want to figure out sooner rather than later. Okay. How am I doing on time? Sorry. Let's go. Okay. So after a month, Kira returns to the clinic with her mother and sister. Her mother's much more stable. They're currently working on obtaining shared guardianship over Kira's care for her sister, and Kira's actually starting adult daycare next week. You follow up in 3 months, and during that 3-month visit, you plan to address preventative care. Okay, so keeping Kira's case in mind and what we've discussed so far, some of the health disparities, I wanted to touch a little bit about some of the health disparities that we see in patients with IDD, and why is it that, we see different outcomes in these patients as compared to the quote unquote general population. So health equity really is achieved when everyone has the opportunity to be as healthy as possible. So, all healthcare practices have patients with disabilities. However, people with disability often face increased barriers to their care. I think in order to bridge the gap in care for this patient population, we really need to understand and address the existing health disparities. So some of these can include limited access to care, again, having a higher prevalence of chronic disease, like the ones we mentioned before, health equity gaps, and then barriers to preventative care. When it comes to limited access to care, again, this can be due to either physical or communication barriers. Insufficient training in healthcare providers is actually something that I think can play into this as well. And then there's healthcare system navigations as well. So whether a patient can physically get to the clinic, do they have transportation? The provider, from a provider standpoint, are they comfortable taking care of this patient population? I think something that I've seen patients with disabilities say is that they don't feel like their provider feels comfortable, and they don't even, sometimes even know how to speak to them, how to address them. A lot of times they come in with their family members, and it's their family members that gets addressed during the encounter. So again, these are all limiting factors to their care. Higher prevalence of chronic disease, we touched upon this earlier, and then health equity gaps, right? So health literacy, depending on, the patient's, IDD and level say if intellectual disability is a diagnosis as well, how engaged and how much of their care can the patient be engaged in. Caregiver burnout is another one that's important, and I think that we don't think about often. And then lastly, barriers to preventative care, so infrequent screening in this patient population, and then lack of tailored programs aimed at this patient population. So you can, tell a patient to go and exercise all you want, but if, say they're wheelchair dependent or, have certain limitations, well, how do you facilitate that? How can you help your patients? Okay. So health promotion. Again, improving access to healthcare. This is something that's important at the provider, institutional, and systemic levels as well. I think we start small, right? So talks like these, I think are important. Learning more about this patient population, about their needs, starting at the medical school level, so that we gain more confidence and become more comfortable taking care of these patients. And again, this is important for all specialties. From an institutional level, right? If you have a patient that has, it's deaf or mute, ASL services, right? Having in-person interpreters. This all becomes even more complicated when you add other social determinants of health too. So in the Newark population where I work, for example, we have a lot of patients that recently migrated, don't speak English, socioeconomic factors, right? Lack of insurance. So all of these things become limiting. So how can we help improve them? Working with our colleagues in social work, for example, and learning as much as we can. For me personally, this is an area where I'm still learning a lot so that we can facilitate for our patient. Again, health promotion includes early detection and preventative screenings. So it's not just focusing on their diagnosis, but how can we keep you as healthy as possible? So the same way we screen for age-appropriate cancer screening for other patients, same thing for these patients, and really making it a priority that they come in for their annual health exams, not just when we have problems. Promoting healthy lifestyles, again, exercise, dieting, in terms that the patient can understand. And again, this becomes important at the institutional level, right? Because we don't all have these resources as providers, so we have to work with our departments, grants, for example. Addressing healthcare, mental health needs. This is another one that's big and very prevalent in this patient population. And then improving health literacy. Okay, and we're almost at the tail end here, but this is just a summary slide of the various preventative health screenings that should be considered for our patients. So in general, according to the World Health Organization, primary care can meet 80 to 90% of a person's health needs over their lifetime. And we want to ensure that this remains true for our patients with IDD. Immunizations, hypertension, diabetes screening, age-appropriate cancer screening, depression. In these patients, right, you don't want to make any assumptions. Do you smoke? Do you drink? Any high-risk sexual behaviors? Because that also tailors the kind of testing that you do. Osteoporosis screening. So our patients, for example, that are wheelchair dependent, you might need to do osteoporosis screening earlier than you might in the general population. So these are things that you need to keep in mind. Advanced care planning is another one that's very, very important, not just for our patients with IDD and complex medical needs, but for everyone. You want to make sure that you have advanced directives and that you know what the patient's and family wishes are before an emergency happens and you're suddenly in the hospital, so that you do right by your patients. Lastly, just a little bit about policy and advocacy. Again, this is something that I'm still learning about, but I think engaging with your medical societies, depending on your specialty, if this is something that you're interested in, networking with other people and groups to see what kind of advocacy efforts are being done. Again, this is the only way, because I think there's much more research that we need to do to learn how to better care for this patient population. And yeah, that's all I'll say about that little bit. Just to summarize here, the goal really is to have a medical home for patients with IDD that involves coordinated and comprehensive care. It is a multidisciplinary approach, and it's not just, healthcare providers, it's our social workers, case management, therapies, all working together, along with our other specialists involved in helping prevent chronic diseases, and making sure that our patients have appropriate healthcare screening. So again, with the goal of improving quality of life and family satisfaction. With that being said, these are my references. And any questions? And that's just my post survey QR code. Thoughts, questions?